Welcome to Roche's Virtual Immunology SLE Investor Event. My name is Leonard, and I'm the technical operator for today's call. Kindly note that the webinar is being recorded. I would like to inform you that all participants are in listen-only mode during the call. After the presentation, there will be a question and answer session. You are invited to send in questions for this throughout the entire session using the Q&A functionality of Zoom. In addition to that, you may also raise your virtual hand to address your questions verbally. For participants joining via phone, to raise your hand, use *9 on your phone's dial pad. When you then get selected to ask your questions, please follow the instructions from the phone and press *6 to unmute yourself. One last remark, if you would like to follow the presented slides on your end as well, please feel free to go to roche.com/investors to download the presentation. At this time, it's my pleasure to introduce you to Bruno Eschli, Head of Investor Relations. Bruno, the stage is yours.
Thanks, Leonard. And could I have the first slide, please? So, welcome to our second IR event in 2026, focusing this time on the phase 3 ALLEGORY results for Gazyva in SLE, which just got presented last Friday at SLE. Today's call is scheduled for 60 minutes, and let me quickly take you through today's agenda. Following my introduction, the first speaker for today will be Jay Garg, our Vice President and our Global Franchise Head of Nephrology. Jay will provide us an update on our pipeline in immune-mediated kidney and rheumatological diseases. This includes the Gazyva development program, but he will also quickly touch on other B-cell depleting agents currently in development. Our second speaker for today will be Dr. Richard A. Fury. Richard is an MD and the Chief of the Division of Rheumatology at Northwell Health. He's a Marilyn and Barry Rubenstein Chair in Rheumatology and a Professor of Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra in Northwell. He is the lead principal investigator of the ALLEGORY study and the lead author, and he has also presented the results last Friday at SLE. Today, Dr. Richard Fury will take us again through the phase 3 ALLEGORY results for Gazyva in SLE. After the presentations, we will have roughly 30 minutes of Q&A. In addition to our two speakers, we will be joined for the Q&A by Stephen Wright, our lifecycle leader for rheumatology and nephrology, which includes Gazyva in autoimmune diseases, but also cefoxitin in IgAN. Could I have the next slide, please? So before we get started, I just wanted to quickly summarize take the opportunity to summarize the opportunity for Roche in immune-mediated kidney and rheumatological diseases. As we have previously communicated, we view the Gazyva peak sales opportunity in immune-mediated diseases to be around $2 billion. This includes SLE, LE, membranous nephropathy, and INS. And as you can see here on the left side, the US, EU5, Japanese markets for SLE, lupus nephritis, membranous nephropathy, and IgAN is expected to more than double from 2050 to 2030, from $5 billion to around $11.4 billion, driven by the launch of various new and innovative medicines with different underlying MOAs. On the right side, I just wanted to provide a quick update on consensus expectations. You have seen this analysis back in September 2025 at Pharma Day. Since then, a lot has happened, and as we just got our latest consensus in last week, I wanted to provide here a quick update where we stand and what has been or has not been captured by the sell-side models. So let me start with Gazyva. Gazyva sales for 2030 are now forecasted to reach $1.7 billion. That's 0.7 billion more than 2025. And what you can see here is that the $2 billion Gazyva immunology opportunity is still not really captured. Cefoxitin in IgAN, which is shown here in red on the right side under potential upside, has been in the meantime included in most analyst models with sales of $400 million forecasted by 2030. Just to remind everyone, we have indicated here a peak sales potential in the range of $1 to 2 billion. And there are two more NMEs I quickly need to cover here as they have become material to the Roche investment case. Sales expectations for giredestrant have now increased from $0.9 billion in 2029 back in September to now $3.2 billion in 2030. So the adjuvant and metastatic opportunities are starting to get captured. And finally, sales expectations for fenebrutinib in multiple sclerosis have hardly moved since last September, despite positive phase 3 readouts in RMS and PPMS, with sales expectations only increasing from 0.7 billion for 2029 back in September to now 1.1 billion by 2030. So overall, we can see some initial adjustments to the peak sales consensus expectations, but clearly there is additional upside once latest results will get presented at medical conferences and as we are nearing the launch phases, but also as we will have additional data, for example, for giredestrant in first-line endocrine-resistant ER-positive breast cancer in 2027. So that's the Pioneer study I'm referring to, where we have enriched for up to 40% in ESR1 mutant patients, and where giredestrant is combined with the physician's choice of a CDK4/6 inhibitor. And with that, let me quickly move to slide 7. This is just the latest immunology pipeline overview. Jay will touch here on many of these programs, including the Gazyva programs, Safaxasen, and also the various other B-cell depleting strategies, including various bispecifics and CAR-Ts, which we are pursuing in parallel to hopefully achieve B-cell reset for various chronic autoimmune diseases. Maybe one other program here to quickly call out, that's afimkibart, our TL1A antibody, where we expect phase 3 readouts in UC and CD in 2027. We will be the second company coming here to market with this novel MOA. And you also see that we test afimkibart already in additional indications, including rheumatoid arthritis, atopic dermatitis, and MASH. And what you also see here that we have the first TL1A bispecific, DP40 times TL1A in phase 2 development. And we just initiated another NME, so far undisclosed MNE in IBD last quarter, which is now in phase 1. Before I close, one other molecule here to be called out. This is our NLRP3/1 inhibitor in asthma. And as you know, we have broader development programs ongoing in the NLRP3 space, with studies also ongoing in neurology with Parkinson's disease and also in CVRM, so for cardiovascular diseases. And with that, I will hand over to the next speaker. Jay, please, over to you.
Yeah, thanks, Bruno. So my name's Jay Garg. I lead the nephrology rheumatology group here in their late stage organization. Yeah, next slide. So as you know, immunology is one of our core therapeutic areas of interest at Roche, and immune-mediated kidney and rheumatologic diseases are a core part of that. So our ambition, our vision in this space is to induce long-lasting remission in this area, and we do this in 3 ways. 1, becoming a global leader in this space, really focusing on the highest unmet needs and transformational disease outcomes, delivering patient and health system value, and then achieve this by using differentiated therapeutic approaches, really with the goal of enabling long-lasting remission and freedom from toxic therapies. And this is really going to be led by our current portfolio in B-cell targeted therapies and complement inhibition. You can go next slide. So I just want to emphasize that these areas are not new to Roche. So we've actually been in this space for a long time, dating back to the introduction or approval of CellCept in 1995 for the prevention of organ transplant rejection. This was followed by Rituxan approvals in RA, as well as GPA-MPA, Mircera for the treatment of anemia due to chronic kidney disease, Actemra for the treatment of RA, giant cell arteritis, as well as SSc-ILD, and then most recently Gazyva and lupus nephritis last year. You can go to the next slide. So in addition to Gazyva being approved in lupus nephritis, we actually had 3 additional positive phase 3 studies. 1 in generalized lupus, 1 in membranous nephropathy, and 1 in childhood onset nephrotic syndrome. In addition, we had a 4th positive phase 3 readout with our anti-C5 monoclonal antibody, crovalimab, and atypical HUS. You know, next slide. And so I just want to call out that CKD is really a core interest of ours. So that it has a significant unmet need, both to the patients as well as to the healthcare system. So CKD is forecast to become the 5th leading cause of death globally by 2040, and you can see the numbers there. In addition, it is a significant impact to healthcare systems. It takes about 24% of the annual U.S. Medicare budget and really costs 140 billion euros annually in Europe. Immune-mediated kidney diseases are really a significant contributor to CKD, and actually on a per-patient basis have one of the highest risks for progression to dialysis or need for transplant. Next slide. So lupus, which is what we're here today, it's really a chronic disease that affects nearly every organ system. So most patients will have mucocutaneous and musculoskeletal manifestations, and renal involvement will actually develop in around 50% of patients. It's a disease of young women, mainly of color, that causes irreversible damage due to really these chronic immune flares. And then the current treatment, or the current aim, is to really induce long-term remission with low-dose steroids. LN specifically can be considered the most severe organ manifestation of lupus. And it's not really that first episode of LN, because that will cause damage to the kidney, but it's also subsequent flares. So the goal of treatment is not only to induce remission or response in those patients, but really to prevent subsequent flares. So up to 3.4 million people are affected by lupus worldwide, again, with about 50% having renal involvement. And then about 30% of patients will actually progress to CKD if they do not achieve a complete renal response. Next slide. And so when you look at the highest unmet needs, so this is a survey done for KOLs. And so their thoughts are that what they need to see from a therapy are really long-term efficacy and safety, which is clear, as well as steroid sparing. Now, at the Euro Lupus, or at least the SLE Euro conference this past weekend, there was a patient group that actually presented their own survey, and they actually queried patients. And what they found was that the biggest unmet need from a patient perspective was a treatment of fatigue, but also getting rid of steroids as background. So pretty significant for them. And then comes efficacy, especially in the kidney realm as well. Now, biologics are expected to rise in the future, at least the use of them. Really, this is driven by guidelines. So the guidelines now are taking more of a treat-to-target approach, where you are trying to get to disease remission. In lupus nephritis specifically, the recommendation now is to start with triple therapy, which is really steroids, mycophenolate mofetil, and then a biologic therapy, either Benlysta, or advanced therapy, Benlysta, voclosporin, and now obinutuzumab has also been included in those guidelines. You can go to the next slide. So Gazyva. So the reason we believe Gazyva has been so successful in lupus and other autoimmune diseases is really because of its deep B-cell depletion that we've seen. So it's really the first glycoengineered anti-CD20 that's been evaluated in autoimmune disease. And what does this mean? It's a type 2 anti-CD20, so it binds differently than type 1 anti-CD20 antibodies like rituximab or ocrelizumab. So this leads to increased direct cell death, decreased complement-dependent cytotoxicity, and reduced internalization. The Fc receptor has been glycoengineered, so it has greater affinity for effector cells, which then will lead to increased antibody-dependent cellular cytotoxicity and antibody-dependent cellular phagocytosis. So there's actually good preclinical data in human data suggesting that this binding conformation and the inhibition or the depletion of these B cells is actually greater than therapies like Rituxan. You can go to the next slide. So in terms of LN, just as a reminder, our initial phase 2 data were in a study called Nobility, where we showed superiority to placebo on the background of MMF and steroids. And this was then confirmed in our phase 3 Regency study, where we showed superiority and complete renal response at week 76. In addition, we showed a greater proportion of patients getting to CRR on low-dose steroids, as well as showing in an exploratory analysis a significantly reduced time to lupus nephritis flare, where we had a 56% reduction in the risk of lupus nephritis flare. As I mentioned, this has actually been included in guidelines so far. And the treatment regimen, just to remind you, is 2 doses at day 0 and week 2, repeated at week 24 and then week 26, and then it'll be 1 dose every 6 months thereafter. Importantly, we also got approval in both the US as well as most recently the EU for short duration infusion. And what this means is that after the first infusion, if the patient has tolerated that well, they can then receive Gazyva in a 90-minute infusion as opposed to a typical 4-hour infusion, which we think will be a significant impact for both physicians in the healthcare system as well as the patient. You can go to the next slide. So Rich will talk about this in more detail, but since it's already been communicated both at SLE Euro as well as in the New England Journal simultaneous publication, as you can see here, this is a trial design where we compared Gazyva in a similar dosing regimen as we did with lupus nephritis versus placebo on top of background immunosuppression in patients with moderate to severe disease activity. It achieved its primary endpoint of SRI-4, and you can see here was a 23.1% delta, which was highly significant. It hit all 5 key secondary endpoints, which Rich will go into in more detail. And I think importantly, it actually hit on some pre-specified secondary endpoints around some higher bar endpoints like DORIS remission, which requires achieving a clinical SLEDAI of 0 on low-dose steroids, 5 milligrams or less, as well as LLDAS, lupus low disease activity. So the remission rate for Gazyva was 35% versus, I think, 14% for placebo. So kind of the highest we've seen so far in a global pivotal trial. You can go to the next slide. Most recently, we had a press release on the phase 3 study Majesty, which evaluated Gazyva versus tacrolimus, a calcineurin inhibitor, and primary membranous nephropathy, which is known to be an autoantibody-driven disease. This was a 2-year endpoint, looking at really a high bar response for a complete remission, which was achieving a UPCR of less than 0.3 with stable renal function. And these are patients that typically start around 6, 7, 8 grams of proteinuria, so pretty significant reduction. This is the most common cause of nephrotic syndrome in patients who are non-diabetic, and about a third of these patients will eventually progress to ESRD and require dialysis. Additionally, we reported last year in a press release around our phase 3 study in childhood onset nephrotic syndrome, where we met the primary endpoint, and again, the first global phase 3 to study a targeted therapy in this disease. It actually received FDA breakthrough designation and has been accepted as a late-breaking oral presentation at the World Congress of Nephrology at the end of this month. You can go to the next slide. So our thought is now, given what we've seen with both Rituxan and now with Gazyva, and seeing the success of Gazyva where Rituxan wasn't as successful, especially in a disease like lupus, that B-cell depletion truly could be a very effective approach in this disease. External data, again, just case reports, case series with both T-cell engagers as well as CAR-T, suggest that if you can get greater B-cell depletion, that actually might lead to even greater responses and potentially even remission. We actually have a pretty strong pipeline in this area that will help us test this hypothesis. So we have a few T-cell engagers, T-cell bispecifics. We have Lunsumio, which is approved for follicular lymphoma already. This is a CD20, CD3 that can be given as an outpatient. The safety profile in follicular lymphoma seems to be appropriate, such that we decided to take it into lupus and lupus nephritis. We've actually run a phase 1b study, which we previously presented at EULAR last year, which showed an acceptable safety profile and did show B-cell depletion in this population. So we are now in a phase 2 study with that molecule. In addition, our colleagues in PRED, our early development organization, are evaluating an NME of a CD19, CD3, which is currently in phase 1 in lupus as well. In addition to this, we have an allogeneic CAR T therapy targeting CD19, CD20 that we have initiated a phase 1 study in both lupus and in MS. And next slide. And so I'm happy to announce that we also have announced positive results of our anti-C5 monoclonal antibody in atypical HUS. So this is a devastating disease in children that can definitely lead to high morbidity and mortality. And it showed positive results. We have not, this will be presented, I believe, later this year at a medical conference. And you can see that we have data both in adults and in pediatrics. You can go to the next slide. And I think lastly, just wanted to talk to you about our phase 3 study in IgA nephropathy with our complement factor B inhibitor. So surfactansin is an antisense oligonucleotide that actually inhibits production of complement factor B. So it inhibits it in the liver and actually has some local effects in the kidney as well, based off of what we've seen in preclinical models. And our thought is that by actually inhibiting complement factor B, we could have a greater effect in IgA nephropathy in terms of the complement-driven inflammation that this has. We actually have phase 2 data that has been recently published in Kidney International Reports, where we showed that there was, in a single-arm study, reduction of 24-hour proteinuria. And then this led us to conduct the phase 3 Imagination trial, where we're comparing surfactansin against a placebo on background, on optimized background standard of care, with a 9-month endpoint for proteinuria to hopefully lead to accelerated approval, and then a 2-year endpoint on eGFR. You can go to the next slide. And with that, I will turn it over to Rich.
All right, thanks, Jay. I'm Rich Fury. I'm the head of rheumatology at Northwell, which is a 30-hospital health system based in New York. My passion is to take care of lupus patients, and in the early 90s got involved in a couple of lupus trials because that's all we had back in the 90s. And now we have a huge number of studies. All right, I had 6 minutes to present this, but I understand today I can take a little bit longer. And I started out just to try to break the ice, talking about allegory being a misnomer. Because remember, go back to your high school English days, an allegory was a fictional piece of work. It was a fictional story with, a lot of symbolism. And this is the polar opposite of that, pure facts. All right, next slide. Disclosures, yeah. So just a little bit of background. And Jay went into this. I could spend an hour on this because it's such an interesting story. If you go back to our early efforts to deplete B cells and see how patients with lupus and lupus nephritis did, what we learned is that we weren't depleting enough. More is better. And so obinutuzumab, and I'll go over this again, is a far more potent B cell depleting antibody than our predecessors. Next slide. And I really like this slide. It's so simple. If you look at the left, you'll see the modifications made to the molecule. So it's glycoengineered. And so what does that mean? It means it was defucosylated. So these fucose groups were removed. And the end result there is that there's less steric hindrance and greater enhancement of binding of the Fc to an Fc receptor. But there were also modifications done to the front end of the molecule, a so-called type 2 binding conformation. And then if you shift over to the right side of the slide, you'll see the results. We have greater antibody-dependent cellular phagocytosis, and at the bottom, antibody-dependent cellular cytotoxicity is increased as well. Because of the type 2 binding configuration, there's greater direct cell death and less dependence on complement-dependent cytotoxicity. This all adds up to just greater B cell depletion. Next slide. Here's the design of Allegory. Similar to other studies done in lupus. So remember, when we study lupus, we usually have a split between SLE and lupus nephritis. So different treatment algorithms and, somewhat different treatment designs. So in ALLEGORY, there were 303 patients who were randomized 1-to-1 to either receive obinutuzumab or placebo on top of their standard of care therapies. And we'll go into the standard of care in a little bit. There were a total of 4 infusions over the 52 weeks. The first 2 infusions constituted 1 course, and that was done at baseline. And then there was second course was done at 6 months. With each infusion, whether a patient got obinutuzumab or placebo, they received methylprednisolone intravenously, 80 milligrams, to prevent any kind of infusion reaction. The primary endpoint was the SRI-4 at 1 year. And we could go into that maybe afterwards if you're not familiar with the SRI-4. The SRI-4 made its debut. I actually presented, as I recall, at EULAR some almost 20 years ago. But it's been, along with BICLA as an endpoint, the regulatory endpoints for our SLE trials. There were a lot of key secondaries. I'm not going to go through them right now. I'll show you on the next slide when I show you results. Oh, but we're not ready for the next slide. I'm sorry. I just want to point out a few more things. So prednisone. Prednisone has been a confounder for our studies. And we know in clinical practice, it's so important to taper prednisone. So we do that as part of our trials. And patients who are on prednisone, which is a good chunk of these patients, were required to try to taper to 5 milligrams or less by week 24, but then from week 40 till the end of the study, so the last 12 weeks of the study, they could not change their prednisone dose. And probably one of the most important features of this particular slide is on the bottom right. This study enrolled very high disease activity patients. So what is a high disease activity patient? We required a SLEDAI of 8 or greater. Most all other studies, the bar was at 6. We required a BILAG A or 2Bs, so just another measure of disease activity. So the patients had to have both. And then, of course, a physician global assessment of 1 or greater. But in addition, they had to be autoantibody positive. So that meant an ANA or an anti-DNA antibody or yet another antibody called Smith. And what was very unique to this study was the requirement for a low complement level, a low C3 or a low C4 or a low CH50. So these requirements added up to a very active group of patients. Next slide. Baseline characteristics. I'll just go through a few of the points here. If you look at what's bolded, means SLEDAI score of a little over 13, that's a very active population. Most of our SLE trials, the average SLEDAI score has been around 10, maybe up around 11. And then what's a little different from other studies, also bolded, background therapies, background immunosuppressives, about 70%. Usually in our studies, about 50%. And in fact, I think the percentage using hydroxychloroquine was a little bit higher. In most of our studies, it's around 2/3 to maybe 70%. This was a little higher. Next slide. All right, so the primary endpoint, the SRI, and it is defined on the left-hand side. So if I have some time, I will go through this. The SRI, in order to be a responder, and it is a dichotomous endpoint, one has to have a 4-point or greater reduction in the SLEDAI score, and they can't acquire new activity in the form of a BILAG A, which is the most active domain score that one can achieve, and or they can't have more than one BILAG B. There can't be deterioration in baseline physician global assessment, and obviously no occurrence of any kind of intercurrent events like changes in medicines, so forth. So is that a rigorous endpoint? It really is. When we first developed this, no one really understood what an SRI was, but it turns out it's a very rigorous, hard to achieve endpoint. But if you look at the right-hand side, you see that 76.7% of patients on obinutuzumab achieved this endpoint, whereas in the placebo group, a little over 53% achieved this endpoint, accounting for a treatment difference of 23 percentage points. How does 76.7% compare to other studies? It's the highest we've ever seen, and I must say, I can editorialize now. When I saw those numbers, my first word was, wow. Next slide. All right, let's go through the secondary endpoints. There were 5 key secondary endpoints. They're listed on the left. The short of it is that every single endpoint, and we've never seen this, every single key secondary endpoint hit statistical significance with the treatment differences ranging from about 22 percentage points up to about 30 percentage points. But let me just run through them since I do have some time to explain them. BICLA is our other regulatory endpoint. And you can see about a 22% treatment difference there. Glucocorticoid reduction to 7.5 milligrams or less. That was sustained for the last 12 weeks of the study. I emphasize the importance of steroid reduction, also significant. The SRI-4 at week 40 sustained. So that not only speaks to efficacy, it speaks to durability. Now you might counter, or people counter, but we know the anti-CD20s can improve complement, they can improve DNA antibodies, and if you normalize both of those, you lose 4 points off your SLE. So was it just about complement and anti-DNA antibody? No, because if you look at the next one down, SRI-6 requires a 6-point reduction, so now you have to introduce clinical improvement as well. And then the last one, time to first BILAG flare. I mean, the name of the game in lupus is to prevent damage. And where does damage arise? Damage arises from flares, from activity. So it's very important for a drug to be able to reduce flare rates. And there's a whole slide dedicated to that I'll show you. And we talked a little bit about additional secondary endpoints. These are not in the testing hierarchy, but I have a slide, and we'll go through DARS and LLDAS in just a couple of slides. So next slide. All right, time to first BILAG flare. And a BILAG flare is defined as a 1A or a 2B that arises. And this, again, is very important. And you can see a hazard ratio of 0.58, which translates into a 42% risk reduction of flare. And again, I can't tell you how important flares are because that's how patients accrue damage. And for each 1 point, we're not going to go through the SDI damage index, but for each 1 point increase in damage, there's about a 30% increase in mortality risk. So damage is very important. Next slide. SLE scores over time. So the main driver of SRI response is a reduction in SLE. SRI-4 means a 4-point reduction. And this just gives you an idea of the kinetics of response. Sustained reduction in SLE occurred about week 24, but you see there certainly is some separation even before week 24. Next slide. All right, DARS and LLDAS. So what are they other than cute names? Well, when patients, not even that long ago, 6 or 7 years ago, asked me, "Doctor, am I in remission?" I said, we don't really use that word in lupus. We talk about maybe control of disease, but now we use that word. And so DARS remission has a definition. It's pretty stringent. And you can see that about 35% of the patients who received obinutuzumab achieved DARS remission by week or at week 52, compared to about 14% on placebo. I can tell you that that's a very high number, 35%. It's a very stringent definition. LLDAS, lupus low disease activity state, achieved by a little over 57% in the obinutuzumab group versus 25% in the placebo group. LLDAS is not as stringent as DARS. And it may be worthwhile just taking a couple moments to talk about, well, how is DARS and LLDAS, how are they different than SRI or BICLA? So SRI is improvement in activity by, as I mentioned, 4 points. Whereas DARS and LLDAS are absolutes. You have to hit a particular state. And the state that of relative well-being is associated with a lot of benefits. Reduction in mortality, a reduction in damage accrual, less healthcare utilization, and the list goes on and on. So to clinicians, DARS and LLDAS are far more important in practice than, say, to SRI and BICLA. I mean, they're all important, but DARS and LLDAS really do stand out. Next slide. B-cell depletion in peripheral blood. An interesting slide that compares the degree of B-cell depletion in this particular study to what was seen in the Explorer study. Explorer we did many years ago. It was a comparison of rituximab to placebo on background therapy. And this particular slide, dark blue are the obinutuzumab treated patients, and gray represents the rituximab treated patients. And every single pair shows that more patients are achieving a threshold of B-cell depletion, which was 10 cells per microliter, with obinutuzumab than with rituximab. So not only a greater percentage depletion across those patients, but it seemed to be more sustained. But this doesn't tell the whole story. We need to know what's going on in the tissues, and though that wasn't evaluated in this particular study, it was evaluated in the lupus nephritis Regency trial, and the data were quite impressive that we were achieving deep B-cell depletion in the tissue of kidneys from patients with lupus nephritis. All right, next slide. All right, what about safety? So there were a total of 4 deaths during the first 52 weeks, 1 in the obinutuzumab group, 3 in the placebo group. And I could spend a lot of time going through this, but let me just kind of shorten it, and we'll go through some of the bolded items. Infections were, in fact, more common in the obinutuzumab group than in the placebo group. So we've kind of seen mixed results across the 3 studies. If you go back to the Nobility lupus nephritis trial, there were actually more infections in the placebo arm. The Regency was the opposite. And here we did, in fact, see more manageable infections, like urinary tract infections, respiratory infections, pneumonia. So more common, but very manageable. We can jump down to infusion-related reactions, more common with obinutuzumab, but these are like nausea and headache. And lastly, drug-related neutropenia. What we've been finding with basically any strategy to deplete B cells is that patients, and we don't quite understand why, can become neutropenic. There were slightly more patients in the OB group that developed neutropenia than in the placebo arm. And let's go to the next slide, which is the last slide. I'm not going to belabor all these conclusions because I just went through them. But the most important one is at the bottom. This was a very active cohort of patients. So be able to achieve a relatively high rate of DARS remission to show that the drug is steroid sparing and that it reduces flares. This is what is so important to the clinicians and also to the patients. Next slide. So I did want to thank all the study participants, not only in this study, but this has been a journey that started about 20 years ago with the rituximab studies, the ocrelizumab studies in lupus, and we really do owe it to the study participants, to their families, and, the study investigators get a little credit, and their staff. And this was simultaneously appeared online at 1:45 Lisbon time on, Friday. So you can look at the article. It has a little more information than what I just went through. And that's it for me.
Thanks a lot, Richard. And with that, I think we will open the Q&A session. The first questions go to Simon Baker from Redburn. Simon, please.
Thank you, Bruno, and thank you for organising this call. A couple of questions. Firstly, Dr. Fury, looking at the subgroup analysis by SRI-4 scores, it looks like a very consistent result across the piece. So 2 questions. Firstly, are there patients where you would not consider using this? And secondly, the one area where there seemed to be an enhanced performance was in people of Hispanic or Latino ethnicity. I just wondered if you had any thoughts on why that was. And then probably a question for Jay. On cell therapy, there's been a lot of activity in the broader autoimmune CAR T space. Just intrigued to see why you're going straight for allogeneic rather than autologous. Is that any specific reasons? Was this really about scalability of the opportunity that allogeneic gives you? Any thoughts? Much appreciated. Thank you.
All right, so first question, who would I not use it on? Well, there's still a lot of data that we need to see. I mean, lupus is not one disease. Lupus is about 1,000 diseases. And we treat by interviewing the patient. I mean, we're so old-fashioned in rheumatology. So we interview, we examine, and we look at labs. And some of the major manifestations of SLE are skin rash and arthritis. I haven't seen the domain-specific data for OB just yet, nor the kinetics of domain-specific responses. But I must say, anifrolumab works very well for skin. It works very quickly. So in all honesty, I think it's going to be hard to compete with anifrolumab in patients with very active skin disease. But again, that's without seeing the OB data. Other than that, patients who are serologically active with arthritis, patients who have a little bit of nephritis, and patients who have a lot of bit of nephritis, they'll get obinutuzumab. So I can't really think of contraindications to giving someone obinutuzumab. Plus, it's very convenient. 2 infusions, and we have a problem with non-compliance and non-adherence. Patients don't take their pills. And so to be able to have them come in for an infusion, and the infusion duration will be decreasing, and then just have them come back 6 months later, it's hard to beat that. You asked about ethnicity. Well, you asked about subgroup analyses. I have such mixed feelings about subgroup analyses because they're hypothesis generating. And if you took them at face value, you probably wouldn't use a lot of these drugs, belimumab, anifrolumab, or obinutuzumab in certain groups. So I can't really explain why the differences. It certainly would be interesting to find out. But again, I think we just have to think about mechanisms, but not take them at face value.
Thanks, Rich. And maybe I'll answer the question. Maybe, Bruno, you can chime in as well. So it's a good question around allogeneic versus autologous. And, if you remember the first slide of what we're trying to achieve for both patients and the healthcare system, an allogeneic off-the-shelf therapy, if it does demonstrate the efficacy we are expected to see with autologous or what we have seen, that would be just from a convenience or accessibility more so factor that it would seem like it would trump the autologous. So that's our main goal. And the data that we've seen with the allogeneic suggests that this is something that we might be able to achieve.
Great. Thanks so much.
Very good. Simon, all your questions answered?
Yes. Thanks so much to all of
Then
them.
we can move on. Next questions would go to Louisa Hector from Bloomberg. No, Louisa dropped off for some reason. Let's quickly then continue with Graham Perry. Graham, please.
Great. Thanks, Bruno. So 2 on Gazyva, actually, and then I've got 2 on Persevere that we've just been asked all day. It'd be good to address. So on Gazyva, just thoughts on commercialization with an IV administration only, given there is a subcut Benlysta, and I think it's about half of patients actually get that. And AstraZeneca is obviously refiled now its subcut formulation there. So is there an advantage to subcutaneous administration? And perhaps Dr. Fury could actually chime in on that one as well. And then secondly, do you expect to see the remission data on label, the Doris remission data on label, given again Dr. Fury indicating the importance of that? And then just the two on persevERA, the question we've been getting all day was the miss due to powering? So did you beat the target 0.85 hazard ratio, but just miss on stat sig? So powering the trial was fine, or do you just see a smaller effect size than the 0.85 hazard ratio? And do you have a sense of whether that fail was due to not enough naive patients in the study that were endocrine sensitive, or does this validate the theory that CDK4/6s negate the advantage of an oral SERD over an AI in combination? Thanks.
Okay, maybe I'll do this in between oncology question first. Graham. It's the big topic of the day. So yeah, what we've seen, we had powered when we were looking for getting a hazard ratio of 0.85, and the effect size was below. We have indicated in the press release there was a numerical benefit. There is, I think, no more I can say right now at this point, but I think let me also remind you that there was a limited number of ESR1 mutant patients in the study, so around 5%. So as said, there was a bit of a benefit. What does it mean in terms of CDK4/6 combination development? I think we have indicated in the press release that we believe that this still is a viable path forward in the adjuvant setting. And I would not agree, what you feel asking basically, does this mean that there is no additional benefit to be gained in combining giredestrant with CDK4/6s? No, I would not draw this conclusion from the data we have seen. And did I miss anything on your, what else, Graham?
No, I think you covered it there. Thanks, Bruno.
Okay. Then let's go back to Gazyva. Yep.
I've forgotten the questions. I guess the first one was sub-Q versus IV. Is that right?
Yeah, exactly. So it's just the importance of potential importance for having a sub-Q, just given I think it's about half of the Benlysta patients take the sub-Q, and Astra's filed for an indication there because I've only got IV. And so if you just talk through the dynamics of that, would be great.
Yeah, so I'm spoiled. We have an infusion unit. It's about 50 feet from where I'm sitting right now. So we can offer either. And it's kind of open discussion, shared decision making, as they say. But IV, every 6 months, I think is pretty easy. And it guarantees that the patient gets the drug. I don't know about adherence and compliance to sub-Q. But I could see advantages I could argue both sides of this. So I don't really have a definitive answer for you.
Got it. Okay.
It's more about how effective the drug is and and then we have other variables. We have to deal with insurance companies and what they're telling us, how to give it, and then resources as well.
And maybe I can take the remission question, because this is something we'll discuss, right, with the health authorities. I do think, just based off of what Rich was saying, the importance of remission to physicians and to patients and in the guidelines seems to be something that should be shared, right, in the label. But that's a discussion we'll have with health authorities. It was not type 1 error controlled, so it wasn't one of the key endpoints, but it was pre-specified.
Got it. Okay, thank you.
I think you're on mute, Bruno.
Yeah, I was just thinking of one question which came here in the chat from Michael Leuchten from Jefferies, maybe also to, access. And the question is about, would you expect that there would be a step through, Benlysta first and then Gazyva, or how would you expect this to develop?
Well, we can distinguish, say, lupus nephritis from SLE. I'll start with lupus nephritis. No, I don't see any step through at all there. And for SLE, I don't see that either, unless it's dictated to us by insurance companies. Mm-hmm. But clinicians will want to use obinutuzumab up front without having to fail other drugs.
Okay. Very good. Then, Graham, we had answered all your questions.
Yeah, thank you.
Yeah, then we move on. Next one is James Quigley from Goldman Sachs.
Great, thank you for my question. I've got two, please. So firstly, maybe for Dr. Fury. So as you think about your typical lupus population, given the inclusion criteria and activity levels, what proportion of your SLE population would this trial represent? Similarly, when you think back to other studies, many of which have failed in the past, did you see any differential benefits between the higher risk groups on the SLE versus the lower risk groups? It doesn't seem to be the case here, but the cutoff used in the subgroup analysis in the New England Journal was greater than or less than 12. So interested to see if you see any differences there with other trials which maybe had lower activity, including criteria. Secondly, for Roche on the bispecifics, you've got one targeting obviously Lunsumio, CD20, you also got CD19. So what are your expectations here for differential B-cell depletion, and then also the why have you got different approaches for each of those assets? So what are your expectations of differentiation between Gazyva, Lunsumio, and then your CD19, CD3? Thank you.
Okay, let me see if I remember the question. So the first question was, what percentage of, say, my cohort here in practice has that kind of SLE? You mean a SLE of 13?
Yes. Yeah.
Oh, very few, unless they have lupus nephritis. But that's one of the problems with SLE. It doesn't tell the whole story. You could have someone with terrible, terrible arthritis or terrible, terrible rash. So the arthritis patient picks up 4 points, and the rash patient picks up 2 points. You might want to use this drug in those patients, even though they don't have the entry criteria that ALLEGORY had. So sometimes they're held to this by insurance companies. You know, for example, with belimumab, they'll go, well, the patient, in order for you to get belimumab approved, the patient has to have a SLE of 6. And then we argue back. That was for the studies. We're talking about practice. So not everybody that we see has low complement. That was part of the criteria to get a high disease activity group. Anyway, so there's discordance between what we actually can see in practice and call severe versus what is severe in a study. I hope that kind of gets to your question. Then you had one about studies with lower disease activity.
Yes. So did you see differential efficacy between the lower disease activity groups and the higher disease activity groups? As in other trials where maybe the entry criteria was for lower disease activity, did you see benefits in the higher disease subgroup of those trials?
Well, in this trial, as I recall, I mean, you can look at the subgroup analysis in the New England Journal, but as I recall, SLE, so the partitioning threshold for entry was a SLE of 12. And as I recall, those above 12 and those less than 12 performed about the same.
Yeah.
I'm going to have to go back and look at the paper, but that's how I recall it. For other trials, with average SLEDAIs of, say, 10 to 11, I have a lot of data swirling in my head. I'd have to go back and look. But so look at the subgroup analysis for this study, and I think your question will get answered.
And then,
or Jake, help me out.
Yeah, no, I don't know. Yeah, no, you're right about our data. I don't know the other data as well. So just a question on our T-cell bispecific. So it's a good question. So we don't know what the best target antigen is, in all honesty. So we know that targeting CD20 works, as we've demonstrated with Gazyva. The hypothesis we're testing with Lunsumio is whether greater B-cell depletion, targeting CD20, will get you greater efficacy. So we have preclinical data head-to-head showing that a CD20 CD3 is superior to a monoclonal antibody targeting CD20 in terms of tissue B-cell depletion. So that's the question here that we're trying to answer with Lunsumio. Again, it's approved. We know what the safety profile is. We've had some initial data on lupus. So we feel interested in understanding what it can do. But the question around CD19, CD3 is a different target antigen that has a broader B-cell expression profile. So this is the data that George Schett has presented with his CAR-T CD19. It does hit some plasma cells that a CD20 might not hit. So that's a question of what can that do? Can it actually induce a more remission-like profile than what you could get with CD20, CD3. So we're testing kind of two separate hypotheses there and understanding what each of these can do. I hope that answers your question.
Got you. That does. Thank you very much.
Yeah.
And we give it a second try. Next one is Louisa Hector from Berenberg. Louisa, please.
Hi, Bruno. Can you hear me now?
Yes, now I can hear you.
Amazing. Thank you. And thank you for this presentation. I'd love to hear from Dr. Fury just thoughts on why the patients are still flaring, what is the biology, and how we might eventually get better control on that. Does it link to simply the B-cell suppression, or that alone is not enough? And in the New England paper, there was some commentary around the response rate to some extent being attributed to modern refinements in trial design. So I'm curious to know what that is, and does that mean, you know, the older drugs run with the same refinements would also look better, perhaps?
You all ask difficult questions. So for the flare, I don't have an answer for you, but that's something that will be analyzed. I mean, you could look at the definitions in BILAG. You can go through what 1A means and a B means, but I don't have an answer for you for these data, but hopefully we will soon. All right, the modern refinements is actually very interesting. I mean, lupus is one of the hardest diseases to study. I mean, we go back to the belimumab phase 2. That's where we learned our lesson. Not all the patients were serologically active. So each study thereafter, patients had to be serologically active. And then we learned something more than that in the next study, So we have made major refinements that I think allow us to say that our patients who are enrolled in the study probably truly do have lupus, and that their activity indices are not overinflated. And then there's some other things that we've added, like steroid taper and so forth. So it's a very interesting question. I mean, if we went back and studied rituximab again, would we see better results? I don't have an answer, and we're not going to do it.
Well, so Rich, I just want to chime in here, because the argument I would make, because one, you participated in Explorer, so you know that was unfortunately pretty negative, where we missed all primary and secondary endpoints. I think the question here, especially with the low complement population, where Rituxan actually depends on more complement-dependent cytotoxicity. We have this type 2 conformation, which deals with or depends less on complement-dependent cytotoxicity. I think in this particular population, it might be hard to say. You may have seen something in some patients with Rituxan. The question is, would you have seen what we're seeing with Gazyva? I don't know. But it seems less likely.
But it is very possible that we had successful drugs, or quote successful drugs in the past, but the study design didn't allow us to see that.
Lucia?
Could I just ask then, so are you more excited to see drugs with even deeper B-cell depletion, or perhaps new mechanisms or combinations, like combinations for the patients might get more or raise the efficacy bar more than the B-cell depletion?
Well, that's a good question. So, if you go back to the Explorer and the Lunar trials, the message there seemed to be more B-cell depletion is needed. So that came from some observational studies up in Leeds by Ed Vitale in lupus and in RA, and then post hoc analysis of the Lunar trial. Anyway, there was a lot of evidence accumulating that more is better. So how do you achieve that? Well, there were a series of studies done with sequential belimumab and rituximab, and there were two strategies behind that. When we did the phase 1 study with belimumab, and now, oh my gosh, we're going back over 20 years, what we saw was actually an increase in memory B cells after the delivery of belimumab. And so some of those combination sequential studies were based upon giving belimumab first to mobilize these B cells, come in with rituximab to get better B cell depletion. There was yet another strategy that was employed to justify these sequential belimumab rituximab studies. And that was when you wipe out B cells, and it doesn't matter how you do it, rituximab, obinutuzumab, cyclophosphamide, you still have a lot of BLyS or BAFF being made, but it has nowhere to bind. But as the B cells return, it's now a high BAFF environment, which may lead to a lot of autoreactive B cells. But those studies were done, and they were done in SLE, they were done in lupus nephritis, and nothing very major. I mean, there's a little bit of pharmacodynamic benefit. I think the last one, I forget what it was called, BLyS, Beat Lupus or something.
BLyS Believe or Beat?
No, it's BLyS Believe, but the one after that done by the fellows in London, I think that was Beat Lupus, saw a lower flare rate. So when I lecture about this, I do talk about those 4 studies, but then I introduce obinutuzumab. And you have B cell depletion data. You have at least 2 studies that I know about. There was one that the folks at Genentech conducted in patients undergoing kidney transplant who had received obinutuzumab because they had been previously sensitized. Not lupus nephritis, as I recall, of like 20 some odd patients, only 2 patients had, or 2 to 3 patients had B cells in their lymph nodes that they harvested at time of kidney transplant. And then you have the 64 patients in the Regency lupus nephritis trial who underwent second biopsies. And they're very impressive data, and you really should take a look. They were presented at ACR, ASN, and then again in Lisbon last week.
Okay. Thank you. Very interesting.
Mm-hmm. And we go to the final person in the queue. This is Steve Scala from Cowen. Steve, the final questions.
Thank you very much. 3 short questions. First, doctor, given the strength of these data, will you switch your Benlysta patients to Gazyva? Secondly, should the oral products be successful in phase 3, such as Rinvoq and Sotyktu, how will they fit into the treatment scheme? And then lastly, for Bruno, could you tell us if the persevERA trial showed an OS trend? Thank you.
Tough, very unanswerable questions. Will I switch a belimumab patient who's doing well? No. Will I switch a belimumab patient who's not doing well? Absolutely. You asked about how will the orals affect all. I mean, it's a problem. We're sort of entering the same kind of dilemma that the rheumatoid arthritis group has had. We were yearning for all these new drugs, and now we have them. We need to know which drug, which patient. So it's going to be dictated by, I don't think it's going to be dictated by comparing SRI and BICLA responses. I think we'll want to see domain responses. We'll think about safety. We need some kind of way to predict who's going to respond to what. And then on top of that, we have insurance companies who are going to tell us what at least in the United States, what the hierarchy will be. So I really don't have an answer for you. And then we have the patients who are prescribed pills and don't take them. That's a big problem. So with hydroxychloroquine, we've had available hydroxychloroquine blood levels in the United States for a lot of years. I can't tell you how many patients. It's like Natalie Costa-Doa told us years ago, patients don't take their hydroxychloroquine. So if they're not taking their hydroxychloroquine, they're probably not taking all their mycophenolate or their deucravacitinib or their upadacitinib, and you can go down the list. So there's something to be said for a parenterally administered drug.
Very good. Steve?
Doctor, in response to your answer, could you tell us what % of your Benlysta patients are not doing well? And Bruno, if you could answer the persevERA question, that would be helpful. Thank you.
Unfortunately, I have to tell you, I also have no answer for you, Steve. So, you have to wait for the data presentation, and we plan to have the data at ASCO.
Thank you.
I don't have data for you. I would say maybe 30–40%. I mean, with Benlysta, you have to be very patient and tell the patient that as well. So I won't declare someone a failure until they've been on it at least 6 months and up to 12 months. But yeah, I should probably take a look at our switch numbers.
Thank you.
Very good. I think with that, we are at the end of today's event. I would like to thank again all our speakers for their time and also their efforts in exploring here new treatment options for patients with severe autoimmune diseases. Let me also thank the IR team members who prepared today's event. I have to call out here Julia Breuer and Sabine Bornkräber and also Melanie Wolf for event organization. I hope the event was helpful to provide a timely update here on our immunology franchise. The next event, which we plan now, will be for fenebrutinib, the FENhance 1 and 2 data and RMS, which will be presented at AAN mid of April. We'll send out the invite as soon as we have a date fixed. And with that, I think if there are any remaining questions, then please reach out to the IR team. We are always happy to assist you and follow up. Thank you.